Hello everyone. Blood cancers represent a complex and often aggressive group of malignancies that demand timely, precise and evolving treatment strategies to improve patient outcomes. Today we examine the latest evidence and evolving strategies in the management of blood cancers. Topics include measurable, residual, disease-guided treatment decisions, emerging targeted therapies for actionable mutations, and combination approaches aimed at overcoming resistance mechanisms. We will also explore the growing role of immunotherapies, including bispecific T-cell engagers, CAR T-cell therapy, and natural killer cell-based treatments.
Welcome to Baptist Health Doc to Doc, a podcast built for innovation and collaboration by physicians for physicians.
I'm Dr. Guenther Koehne, Deputy Director and Chief of Stem Cell Transplantation with Baptist Health Miami Cancer Institute, and joining us for our discussion is Dr. Firas Al-Chair, Chief of Leukemia Service and Medical Director of Infusion Services with Baptist Health Miami Cancer Institute. So, Dr. Al-Chair, let's dive into the advances made in targeted therapies for actionable mutations. What has evolved in this sector recently?
A great has been done over the course of the past few years. As you notice, in blood cancers particularly, we have shifted the classifications of many of blood cancers based on the mutations, the genetic mutations that are tested in those blood cancers. Subsequently, we have realized that targeting these mutations can actually provide treatment options for our patients. For instance, in blood cancers such as leukemia or myeloma or lymphoma, now we have many mutations for which we have oral therapy, targeted therapy, or even intravenous therapy that we can give to our patients. And many of those targeted therapies, they lack many of the side effects that we used to see with old school chemotherapy. And the good thing about it is that it controls the cancer, it provides good quality of life for the patients, and it prolongs their life. I think this is a great option for our patients. What do you think?
Yeah, I totally agree. I think it's critical to really make the difference between the different diagnoses that you mentioned, leukemia, MDS, multiple myeloma. They are all treated specifically these days. And even within the disease entity, such as leukemia, years ago, we treated all the AMLs the same with the same induction therapy. Multiple myeloma had a certain form of induction and maintenance treatment. Now we have specifically targeting mutations in each of the categories and each of the diseases, and are now in the position, frankly, with those drugs to remove or exchange chemotherapeutic approaches with biotherapies or immunotherapies. I think exciting times, complex. We will likely talk about a little bit more in a little bit about the different approaches for each of the diseases.
Absolutely. Dr. Koehne, can you give us some insights about combination therapies to overcome resistance mechanisms in cancer treatment?
Yeah, this is also a very critical question. Now, we know there are different ways of the tumor cell to really escape the immune recognition or develop resistance mechanisms. There are different ways to describe this, but let's just say drugs will be faster eliminated by the tumor cell and therefore a resistance is developed. Or most importantly, I think, is the downregulation of the targeted antigen. So for example, CAR T cells that are targeting CD19 or CD20 or one molecule on the tumor cell have the tendency to evolve or escape the recognition by downregulating it, or by tumor escape mechanisms that those few cells that were negative for the targeted marker will induce the relapse disease. So there are new strategies now to try to prevent this escape mechanism by targeting two molecules at the same time. Well, that makes some sense, more or less, so that we have a prevention of the escape mechanism. But in addition, and we'll likely talk about the CAR T cells in a little bit, there are also approaches to maintain the duration of the CAR T cells within the body or within the bloodstream to have a better surveillance over a longer time period to prevent escape mechanisms. So, Dr. Al-Chair, we also have a very fine detection method to detect residual disease. We call it MRD, or minimal residual disease. Very sensitive test results that can describe the resilience of one tumor cell within millions. So can you elaborate on that? Is there anything in particular that we can utilize to strategize our treatment approaches?
Absolutely. So measurable residual disease, previously known as minimal residual disease, is actually the tiniest amount of cancer that can be discovered or detected in a human body. In the past, we didn't have the methods to detect it at such a low molecular level. These days, we have many options for many types of cancers to detect the cancer cells, as you just mentioned, even one cell in a million blood cells. And we can determine if that is a cancer cell or that's a healthy cell. What's important about that is that we thought in the past that, curing cancer is basically when you cannot find it in a bone marrow biopsy, or you cannot find it on a CAT scan, or, whether any other modality that you test for. These days, we're aiming to get rid of that MRD, or the measurable residual disease, and hoping that this would extend the survival of the patients, as well as make sure that the disease is in a much better control. We did talk about targeted therapy, and one of the good things about targeted therapy is that by targeting that particular mutation, it can actually lead to a much deeper measurable residual disease negativity. And of course, we're going to touch upon it in a second, is the immunotherapy that can help by eradicating that MRD and subsequently providing much better cure outcomes for our patients. And speaking about CAR-T, what do you think about the advances in immunotherapy in cancer, such as CAR-T? We talk about BiTEs, which are bispecific T-cell engagers, and NK cell or natural killer cell therapy.
Yeah, thank you. All very important therapies that evolved over the last few years. Lots of novel approaches, lots of new questions coming up. As I mentioned in my first section, so bispecific T-cell antibodies are very different than CAR T cells, for example. And then we have other immune effector cells that can also get to the tumor cell to specifically bring an antibody to target the tumor cell specifically. Now, bispecific antibody therapies, in contrast to CAR T cells, differentiate by the bispecific T cells bringing the endogenous T cells to the tumor site. So the monoclonal antibody gets to the tumor site, and the binding arm, CD3, allows then the endogenous T cell to bind to the arm and therefore get in proximity to the tumor cell. In contrast, CAR T cells are genetically modified from the blood of the patient and will then be introduced by infusion with the marker already expressed targeting the tumor cell. Now, all of these therapies have been very active and very, effective in inducing responses. Now, the question now comes up, are there differences between BiTEs, for example, and CAR T cells? Yes, they are based on the production that I just described, but in efficacy or efficiency, we don't really know whether or not there's one better than the other. It may be, but it's also individually very different. And most importantly, the question now is, if we have one targeting the antigen, should one be preferred over the other in terms of timing? So in other words, is there a first line and a second line of immunotherapies? And that has not been cleared or determined at this point as well. We are very happy to have these options. Years ago, we had to tell the multiple myeloma patients, we gave you all the drugs that we have. Now we have a third line, a fourth line, a fifth line of treatment, similarly in MDS patients or in patients with acute myeloid leukemia. And therefore, we are very happy and proud that we have another option to present alternative to the patient. Now, with respect to the point before, minimal residual disease is also a sensitive issue that needs to be addressed post-treatment and particularly post-transplantation. If we know this patient has minimal residual disease post-autologous stem cell transplantation for multiple myeloma or post-allogeneic stem cell transplantation for acute myeloid leukemia, we shouldn't really wait until the disease is in full relapse And that's one of the new evolving strategies to really implement maintenance treatments based on the availability of therapies that we have to specifically target minimal residual disease, which also is not necessarily associated with significant side effects. You agree?
Absolutely. And I just want to add that, these BITE therapy and other types of immunotherapies, we do offer them at Baptist Health Miami Cancer Institute at our Infusion Center for our patients. And we're very proud that we're able to provide our patients with this forefront therapies and the latest, whether it's FDA approved or on clinical trial for our patients.
I agree. There was also an alternative question about, do CARs, chimeric antigen receptor modified cells, always have to be T cells, because we are always talking about CAR T? And the answer is no, it doesn't necessarily have to be, because there are also NK cells that can be transduced with the CAR construct, which can then be infused and go to the tumor cell and can induce a long-lasting remission or response and remission. This was led by groups at MD Anderson Cancer Center, and there are NK cells that are off the shelf that can be transduced to infuse into the patient. It's a novel approach, while, as we all know, the CAR T cells have to be generated from the patient, him or herself, and that is a 6 to 8 week time period, and not every patient has that time to wait until we can effectively treat these patients. So there are lots of novel approaches that will come into clinic. In addition, coming back to my previous point, CAR T cells targeting one antigen may not necessarily be the final answer either. So there are new strategies to have dual-specific CAR T cells coming, targeting CD19 and CD20, or CD19 and CD22 at the same time. And importantly, really interesting approach that the co-stimulatory molecules that we know of, CD28 or 41BB, induce a different duration and response within the patients. So now there are novel approaches to have a dual-specific CAR with dual-specific co-stimulatory molecules, which will allow, for example, the CD19, if it's associated with co-stimulatory molecule of CD28, to develop a fast response. We also know that these cells don't last that long, while those that are associated with 41BB have a slower onset of effect, but they last longer. So now that goes back to how can we prevent resistance mechanisms. So here we have an immediate onset with short duration and a slower onset, and therefore an overlap with a lasting duration of responses. So looking forward to these clinical trials that are coming pretty soon. And then lastly, one of the fathers of CAR T cells, Michel Sadelain, which has been my friend and my collaborator at MSKCC for many years, who developed the CAR T cell approaches, and the other one's Carl June at UPenn, who now also just described a new approach of CAR T cells, which he names armored CARs, which is the targeting molecule associated with interleukin 18, and therefore these cells have a longer duration within the patient population. So I think all in all, we have exciting treatment approaches, but as it looks like, we're just at the beginning of all the immunotherapies, and it's just looking an exciting time and looking forward to it. But we have long-lasting remissions in patients that we could not expect years ago without these treatment approaches. So thank you, everyone, for joining us. This brings us to our close. Blood cancers remain among the most complex and rapidly evolving areas of medicine, requiring continuous learning and adaptation. As research deepens our understanding and expands our therapeutic options, staying current is critical to delivering the best possible care. We hope today's conversation offered insights that inform your clinical decisions and encourage ongoing inquiry. Until next time, thank you for your commitment and for your advancing hematologic malignancies and improving the outcome and lives of your patients. Thank you, Dr. El-Chair.
Thank you, Dr. Koehne.
Thank you.
To find out more about the topics covered on Baptist Health Doc to Doc, please visit physicianresources.baptisthealth.net.